Hello everyone, this is Dr. Minister again. So why hypomagnesemia causes refractory hypokalemia?
Potassium is the main positive ion inside our cells. Its balance depends on kidney function, the sodium-potassium pump, the hormone aldosterone, and the electrical potential across cell membranes. Magnesium, on the other hand, is a vital helper for many enzymes, especially the sodium-potassium pump and the renal outer medullary potassium channels, known as ROMK channels, in the distal part of the kidney. When magnesium levels are normal, it blocks these ROMK channels inside kidney cells. This prevents excessive potassium loss in urine. But when magnesium levels drop, this protective block is lifted. The ROMK channels stay open, and the kidneys start wasting potassium even if you give potassium supplements. Low magnesium also slows down the sodium-potassium pump, which means potassium cannot move properly into the cells and stays in the blood, only to be lost again in urine. In some cases, low magnesium also stimulates the renin-angiotensin-aldosterone system, which increases aldosterone and causes even more potassium loss. So, the result is simple but crucial. If you do not correct magnesium first, any potassium you give will just leak out again. That is why in patients with persistent or unexplained low potassium, you must always check and replace magnesium first, or at least along with potassium. In treatment, intravenous magnesium sulfate is given 1 to 2 grams over 1 hour, and then potassium chloride 10 to 20 milliequivalents per hour is added after magnesium correction, with cardiac monitoring if needed. Clinically, a classic example is a patient with chronic diarrhea or long-term diuretic use who has low potassium that does not improve despite intravenous potassium. When magnesium is replaced, potassium levels normalize quickly, proving magnesium-dependent potassium wasting. In short, magnesium is the hidden key to fixing refractory hypokalemia.